Hello and welcome everybody. We have a really interesting, well, I'm sure it will be, hoping it's going to be very interesting, webinar with Dr. Ashish Gulve today. We're going to be concentrating on the different options of treatment for those with neuropathic pain. Now, probably a good start would be to get Ash to introduce himself, but then explain what this type of pain is and how we can best manage it, because I'm sure lots of people might have this pain and not even recognize the type of pain it is. And we all know those with chronic health conditions do suffer a lot in this area. So welcome, Ash.
Thank you. Good morning or have a good day, everyone. So just a brief introduction of myself. I'm Dr. Ashish Gulve. I'm a consultant in pain medicine at James Cook University Hospital, Middlesbrough. I'm also president of the Neuromodulation Society of UK and Ireland and honorary treasurer of the British Pain Society. I've been practicing pain medicine now for over 16 years, and large part of this does involve treating patients with neuropathic pain with neuromodulation techniques.
And your patients that come to you is with neuropathic pain. I mean, perhaps you can just describe to us what that means, as opposed to, how does that differ from normal pain?
Sure. So, Miss, let's start exactly how neuropathic pain is defined. So, when somebody develops pain because of dysfunction or damage to the nervous system, we develop neuropathic pain. Now, the differences in the presentation of this neuropathic pain involves number of features. So a lot of times patients will describe spontaneous pain or a provoked pain. Spontaneous pain, where the pain could be continuous or intermittent, they will get sharp pricking sensation, they will get pins and needles in the area of the pain, there will be shooting type of electric shocks like pain. Some people describe it like a really bad toothache type of pain. There could be burning sensation, there could be hypersensitivity, there could be annoying tingling all the time in that area, or there could be area of numbness, but severe pain in that numb area. People will feel that there is a kind of a water running over that part of the body when there is nothing there, but the sensation of water running, or somebody pouring hot water on that part. They sometimes notice change in color, appearance of that particular part of the body. So there are these kind of various features that distinguish neuropathic pain from what we call is a nociceptive pain, where patients have a pathology, say like pain of arthritis. You only get it when you're bed-bearing, and you don't get tingling, you don't get sharp pain, you don't get hypersensitivity with that pain. That is kind of a way you differentiate neuropathic pain, especially on careful history taking and examination.
And would people, is that the type of pain that you get, would people, when they come to see you, but presumably because they've already been referred by their GP to you or whatever, would they know it was called that type of pain already at that stage? Or would
Not
you
really.
think that
Not really. A lot of times, referring clinicians, whether they are primary care physicians or specialists, do not give this diagnosis of neuropathic pain. Patients are generally referred for their pain, and then it is up to the specialist in pain management to determine is it neuropathic pain or what kind of pain this patient is suffering. Saying that, it doesn't stop any healthcare professionals to take careful history and do the examination to diagnose the character of the pain as neuropathic pain.
What causes this pain? Why do you have this type of pain?
Yeah, it is because of the dysfunction or damage of the neuronal system, the nervous system. So this could be because of surgery, it could be because of the disease processes like diabetes, shingles. Large proportion of patients develop this kind of neuropathic pain following back surgery or a surgery on their neck, like sciatica, that doesn't get better in spite of technically successful surgery. So those are the common causes. People develop it after cancer treatments as well, as a consequence of chemotherapy, radiotherapy, or surgery itself. Surgery is like total knee replacement, any surgery that involves opening of the chest, abdomen. Those patients can develop neuropathic pain as well because you are damaging the nerves. We got nerves everywhere in the body, and these endings on some occasions after injury or surgery, they don't return back to normal function, and they are hypersensitive. They keep on sending pain signals when there is nothing to cause pain.
Gosh, and I suppose that must be really frustrating. So you've had this big surgery. Quite often you might have been waiting for surgery for a long time to sort out an issue, and then you get better, you recover from the surgery, but you're left with this kind of pain afterwards, which must be very frustrating to deal with.
Absolutely, and it also hinders patients' rehabilitations after surgery and getting back to normal life. Fortunately, not everybody experiences that kind of neuropathic pain after surgery, but depending on the type of surgery, the incidence of neuropathic pain following surgery could be anywhere between 5 to 30%.
Oh gosh, so it's quite a high incidence.
It is, yeah.
Is it something that, even for example, in primary care, are doctors aware, or do doctors brush it off by saying, well, no, you will get better and it will be fine? Do they understand that actually this is a consequence of damaged nerves, etc.?
I think there is some degree of understanding about this in the primary care as well, and large proportion of patients will get better in 6 to 18 months after indexed surgery or injury. But you still get those 5 to 30% patients who don't get better over that time and have got ongoing pain, which is described as moderate to severe.
Okay. So I'm just having a look at this sort of order. So on the pain, we were talking about how pain is measured. Is it important for you to understand, in order for you to work out the treatment plan, as to the level of pain that a patient is experiencing?
Sure. So traditionally, we used to measure pain in terms of its severity, and you would have heard of the numerical rating scale, where we ask question on what somebody's pain is on a 0 to 10 scale. If 0 is no pain and 10 is worst pain they can imagine. And that is the commonest bedside measure or clinic measure to ask about the severity of the pain, or you just say a simple description of moderate and severe pain. But what happens is that over time, our memory goes. So what is 8 out of 10 today?
Yeah.
You treat that, and then it becomes 4 out of 10. But then 6 months later, that 4 out of 10 feels as bad as 8 out of 10. And that's why this kind of just the of a severity of the pain is not the best way to measure pain. And now increasingly what we look at is measuring the impact pain is having on patients' quality of life. How does it affect their function? How does it affect their sleep? How does it affect their mobility? And according to that, how does it affect their mood? Because, pain has got impact on the whole person. And that's why now we are looking at the pain in terms of its impact on function. And we measure different things. There is a EQ5D, which is European Quality of Life Questionnaire, which has got 5 domains with 4 responses in each category. And that is pretty constant, uniform, validated measure across the world. The quality of life, as reflected, differs in different countries. One is perfect health, is being dead. But we do often get patients who score negative on that EQ5D because neuropathic pain is so severe and it affects them so badly. So we are now measuring, apart from just the severity of the pain, we are measuring the consequences the pain is having on this patient's function and well-being, and monitoring that, because that is more reasonable outcome than just looking at the number of 0 to 10. And we call it as secondary outcome measures.
And I think also, having spoken to many people about, regardless of their condition or whatever it is, and when you're talking to people about pain, patients find that so much easier to be able, because they would much prefer to express, this is how it has affected my life.
Absolutely.
You know, and that's when you can really gauge the impact, as you say, of pain. And it seems to be, from my limited understanding, that more and more things are based on somebody's quality of life as opposed to the severity, which could be anything. As you say, one day it could be 1 and the next day it could be 5, but it's exactly the same. If one could measure pain specifically and get hold of it, it seems much better to do the quality of life. And as you said, the mental health side of it is so important to understand. I suppose also that understanding, as well as then how people are going to react to the treatment path that you put them on as well.
Absolutely, because we can't cure pain completely. We can't make people pain-free when they are in a chronic pain situation, unlike acute pain that you develop after surgery or after any injury. Once the injury is healed, once you're healed from the surgical trauma, generally the pain goes down completely and can go up to 0. Well, chronic pain continues for months, years. So the whole emphasis of treatment of chronic pain is reducing the severity of the pain, secondary consequences it has got on patients' quality of life, and the aim is to improve quality of life and function, irrespective of what kind of treatment we are offering to these patients with chronic pain.
Absolutely. So moving on now, so understanding somebody's level of pain then obviously dictates what that pathway is of pain management. And can you sort of talk me through those various stages that one might go through?
So, like any treatments that we offer in the healthcare, once you have the diagnosis of chronic pain, generally it will be first tried to managed in the primary care with simple medications and physiotherapy, rehabilitation input into there. And there are different types of medications that work for different types of pain. And those medications also have limitations. And then the patients can, if they don't respond very well, patients can be referred to a secondary care or a tertiary care pain clinic, depending on the type of problem that they have. And it involves taking careful history, detailed physical examination if required, ordering some investigations if indicated, and then developing a management plan, which can include not only specialized medications that work on specific type of pain, but also supporting patients in a multidisciplinary pathway involving specialist nurses, physios, occupational therapists, and psychologists. The role of the physiotherapist is not to get somebody physically fit, but teaching patients, training them on how to cope with their pain, how to reduce the impact pain is having on their normal activities of daily living. Because otherwise it becomes a vicious cycle, activities of daily living, their pain, and then there is what we call as a pain avoidance behavior. Then patients don't do any activities and they become dependent on others. So that is the role of the multidisciplinary team that comes through. And then any interventions that we as the doctors offer is to give them that relief from the pain where they can cope with those rehabilitation techniques. We are not about cure, we are about giving that relief where patients can cope, recondition themselves so that near normal function and quality of life.
Because quite often, as I understand it, is that with all of these things, is once a patient has understood that there isn't this, and we all know that cure is a very tricky word to use, is understanding for some people they need to mourn what their past life would was and what they could do, but then moving on, okay, so how do I manage this on a day-to-day basis, isn't it?
Yeah.
Which is exactly what
Yeah.
you're saying. And it's I imagine it's the I've got too many words in my brain to get them all out. It's your mindset, which is the important bit, to get the mindset, which is what you're saying about having this multidisciplinary team, in order for you to say, well, okay, this is how I am, and if I do this, this is how it can improve how I am. So I can see how it's so important to have, and in this age, we're all so busy trying to pop a pill. Sadly, so many people are just offered pills and expect an instant cure. And that's
absolutely. So the whole thing about pain management is accepting. So there is also, we call it Acceptance and Commitment Therapy Act, because that is what we are trying to do, is accepting some of the limitations this pain has put on somebody and committing them to work around those limitations to improve their quality of life. And it is also about reassurance, because traditionally we think pain is a warning sign. That means there is something wrong, there is the impending doom. But that is not a situation in scenarios. It's okay if you're having angina, you get chest pain, that is a warning sign. But that is completely different than patients with chronic pain, where pain is not indicating any ongoing disease process or an impending doom. And that reassurance is very important for patients to then move on in improving their quality of life.
Yes, absolutely, because fear is, pain and fear go hand in hand. That's our natural instinct, isn't it?
Absolutely, yeah.
So having decided that, if we're now moving on specifically to focusing on the neuropathic pain and the different types of treatment, which we've just said through the multidisciplinary team, is the neuromodulation, which is what we're going to discuss now, is that quite far along the pathway of treatment? I mean, I suppose actually what we need to do is define what neuromodulation is and then discuss at what point it might be offered.
Sure, yeah. Neuropathic pain, I think it is important first to differentiate between neuropathic pain and other nociceptive or pain that you develop after trivial injuries. The mechanism, the way the body processes that pain is completely different. And hence, there are simple medications like opioids, codeine, tramadol, or morphine-like medications in different forms that don't work effectively for neuropathic pain, because the mechanism of action of this medication is different than the pathology that causes neuropathic pain. So this one is quite refractory. So a lot of times medications like anticonvulsants or antidepressants, so medications like amitriptyline, nortriptyline, duloxetine, which come into the category of antidepressant medication, but they work on the nervous system to reduce the pain. And the reason we healthcare professionals prescribe those is those are specific. They got mechanism of action that is pertaining to neuropathic pain. And similarly, anti-seizure medications like gabapentin, pregabalin, and henceforth, those are also useful medications. Every medication has got its own side effects. We heard about opioid epidemic and the number of opioid-related deaths and the addictions that are there, and interactions with various medications, the tolerance that you develop with opioids, and also the high dose of opioids can make chemical changes in the body, which will amplify the pain rather than relieving the pain, which is a very difficult concept for patients to understand. Similarly, with the medications like gabapentin, pregabalin, there is addiction potential in those medications as well. It is about balancing the risks of those addictions, dependence, visible benefit of improving the pain. So that is one thing about the treatment options that are there. So neuromodulation used to be last stop in the treatment pathway of these patients. But what we have realized is it is important to offer this earlier in the treatment phase. So once you have tried simple measures, all the medications in the simple analgesics, specialist medications like antidepressants, anticonvulsants, you had specialist physiotherapy from the specialist pain physiotherapist to desensitize that X, Y, and Z. And under certain conditions like shingles, or when you got sensitivity, there are chili creams, capsaicin creams, topical treatments. Once you have exhausted those options, before you actually try strong opioids, neuromodulation should be the therapy that should be considered, because it is now, especially in the last 10 years, has got the highest evidence in terms of effectiveness in neuropathic pain. What does it involve? So in simple terms, I tell my patients, it is like a pacemaker of the nerves. The pacemaker of the heart makes the heart behave normally, beat at a normal range. So similarly, this is pacemaker of the nerves, which involves putting 1 or 2 wires into the epidural space of the spinal cord. So you're close to the main nerves. So these wires go up to the middle of your spine, or up to your neck if you're treating somebody's arm. And they're connected to a small machine like a pacemaker, which gives tiny electric current to change the behavior of the nerves. And it is not one-off therapy. It is generally going to be lifelong therapy that these patients would require. Patients also have their own controller with which they can change the settings of the machine within a range that we give them, safe range. And also they can switch it on and off if required. So that is what generally the neuromodulation, in terms of electrical neuromodulation. There are other therapies, which involve pharmacological neuromodulation, where oral medications, or very rarely we can, certainly in a cancer scenario, deliver medication directly within the spine, that is CSF, that is the fluid surrounding the spinal cord. That is a very niche area.
So is it similar to like a TEDNS machine?
Yes, that is the common questions we get asked. Yes, yeah, and no, the mechanism of action is completely different than a TENS machine. So TENS machine works superficially on the muscles, and it can have some impact on the nerves, but the mechanism of action is completely different. The target, which nerves it stimulates, is completely different. So even if somebody has not responded to TENS machine, they will respond to neuromodulation if they got the right diagnosis. And vice versa, responding to does not always mean that those patients will respond to neuromodulation techniques.
So with the so presumably it's a surgery. It's a medical device that's inserted into the body. Absolutely,
it's a small operation, which is generally now done on a day case basis, so patients go home same day, and it is a relatively small operation, similar to insertion of a pacemaker device, and it is done in anesthetic and a little bit of sedation to relax the patient, so it doesn't require general anesthetic either.
Is it? I know that we've discussed before some neuromodulation, and it particularly for I think it was for the bladder, and it was very much that you try it first externally, and if you respond well to it, then it's then inserted. Is that the similar type of thing?
So yes, it can be done in the similar way, where you try it, where the wires are external, and then if you respond, you go ahead with a permanent or full implant. However, a recent study that we did, which was funded by National Institute for Health and Research, NIHR, in the UK, did show that because 90% of the patients within the UK population proceed from a trial to having a full implant, the study showed that it is safer ahead with single stage implant without a trial. It is cost effective. We also did a qualitative study of patients, and the patients preferred that approach as well. But if patients want trial, or we clinicians feel that that particular patient requires a trial, then yes, they can have a trial.
Okay, and then once it's inserted, and you can then, as you said, you can then presumably dial up, dial it down, depending on what you fancy.
Yeah.
How often would the device need to be replaced?
So depends on things that the patients require. We get devices that are rechargeable, a bit like wireless charging of the mobile phones, and those rechargeable devices can last between 10 to 13 years. And then there are devices that are not rechargeable. We call them primary cell, so like our normal batteries. And depending on the settings that the patients require, those non-rechargeable devices can last anywhere between 3 to 8 years.
But as you said, it doesn't sound like it's a very, I know it's a quick operation. Is it regarded as very invasive or minimally invasive?
Okay, I would say it is minimally invasive procedure. And it is a reversible procedure. So if it doesn't work, it can be removed. You are still left with the scars, but the device can be easily removed, similar to the way it is put in. So we call it a reversible procedure.
So, and how popular is this in the UK? Is it something that is lots of people are offered it, or?
Yeah, so it has been used in the UK since early 1990s. In 2008, NICE, National Institute of Clinical Excellence, supported this therapy for various neuropathic pain indications. But in spite of that, a recent study in the UK showed that less than 1% population with a diagnosis of neuropathic pain gets spinal cord stimulator.
Gosh.
In the UK, we do between 1,500 to 2,000 procedures per year. So we are doing about 1,500 to 2,000 new patients every year with this condition, but that only represents less than 1% of the population diagnosed with neuropathic pain. And there are various factors that have reduced the access to this therapy. One of the important factors is awareness, the effectiveness of the therapy, and appropriate referrals to a tertiary center that offers this therapy. We've got centers in most of the regions of the country where people can access this therapy. But some of the centers would not accept direct referrals from the GP, and they have to go through a secondary care pain clinic. And those kind of bottlenecks sometimes reduce the access to the therapy. One indication is diabetic peripheral neuropathy. About patients will have painful diabetic neuropathy after their diagnosis of diabetes, type 2 diabetes. And we hardly see those patients being referred to the pain clinics for this kind of treatment, let alone medication management treatment, you know. So,
gosh, and surely it would save so much money and time and heartache for people if they were offered the opportunity of this treatment much sooner, or if at all.
Absolutely. Like any treatment, every patient with neuropathic pain would respond to this therapy.
Yeah.
What we have seen overall in general in routine clinical practice outside the clinical studies is about 2/3 of the patients will get 50% or more improvement in their pain and function. And after that, similar numbers, about 2/3 of the patients are able to significantly reduce their pain medications or come off them. So generally about 1/3 of patients are able to stop all their pain medications. Third are able to reduce them significantly, and as a consequence, not have the side effects that compromise their quality of life.
I mean, it seems like a no-brainer, obviously, but as do so many things in healthcare, isn't it? So, I mean, commercially, economically, it seems the way forward for people to at least try it, and then also for the, for patients themselves, how much the relief that they will get is huge.
Absolutely. So initially, what we call is the acquisition cost is higher because it is an expensive device. When we implant it, the initial cost is higher, but because of the improvement in patients' quality of life, function, and their reduction in usage of healthcare systems, frequent GP appointments, frequent re-referrals to the secondary care. After 3 years, the therapy becomes cost effective. Service, because then you're saving money on avoiding unnecessary investigations, unnecessary GP visits, unnecessary referrals to the secondary care pain clinics or other specialists.
So if anybody who's listening to this and thinks, well, actually, I have this pain, I would be really interested to see if it would help me. what should they do? Go and speak to their GP first about it?
Absolutely, yeah. They need to speak to their healthcare professionals if they are in the primary care GP, if they're with the secondary care specialist, whether it's pain specialist, spine surgeon, neurologist, they can mention, they can ask, I've heard of this. Will I be a suitable candidate for this? Can you refer me to appropriate clinic where I can be assessed for this therapy?
Gosh, no, I mean, I'm sort of quite blown away by the figures that you've mentioned of the improvement, but also at the same time, the lack of number of operations that are done on an annual basis. They don't seem to equate.
Absolutely, absolutely. And it's about raising awareness of the therapy. People often get scared. People often have historical data in terms of complications and effectiveness. But over the years, over the last 20 years, there has been huge development in the field of neuromodulation. And some of the shortcomings we had in 80s and 70s are no more there.
Yeah.
The effectiveness of the therapy has increased. The complications have significantly gone down.
Well, that's all really, really positive, isn't it? So on that note, positivity, is there anything else that you would wish anyone to know about neuromodulation?
So the only thing I would summarize in my last comment is a highly specialist treatment such as spinal cord stimulation, stroke, or neuromodulation, the way we call it, in patients with neuropathic pain. And some of these examples of neuropathic pain will be patients who have technically successful spinal surgery, but they're still experiencing significant leg pain, or we call it sciatica, and there is nothing more that can be cured by surgery. Patients who develop severe neuropathic pain after injury, like fracture of their wrist, fracture of their ankle, or any kind of surgery on the body, this therapy is effective. We can also treat some intractable headaches, like cluster headaches, which are also called as suicide headaches with neuromodulation techniques. And patients who are cancer survivors, patients whose cancer is cured, but they are having severe neuropathic pain as a consequence of the radiotherapy, chemotherapy, patients with hernia, post-hernia repair, when they have chronic pain, neuropathic pain in that area. So the indications are quite a few. And it is important if you have severe pain that is significantly limiting your function and quality of life, then please ask your healthcare professional to get referred to the specialist pain clinics where you can be assessed for this therapy.
Brilliant. Well, I feel that I've learned a lot about pain today, so thank you very much. And, let's hope that we can raise awareness within both, primary care and also with patients, as that there are options. Don't give up, keep looking, because also with medical advances, as you say, have just come on leaps and bounds.
Absolutely. Thank you, Katrina.
Thank you very much for your time. Goodbye, everyone.